So how about the patient who is unfit for chemotherapy? I want to come to the discussion of BCL2 and hedgehog inhibitors from my colleagues. I'll set the stage by saying in these patients that are poorly defined as unfit for chemotherapy or older patients, we all have a different cutoff. It is definitely not 60 anymore either. It's got to be older than that. We've been using hypomethylating agents, azacitidine, decitabine. Basically response rates, CRs, CRIs, depending on how you grade them, 20, 25%, you can argue over the numbers. Very similar with low-dose cytarabine, 15, 20%, but they're all in the same range. Gemtuzumab also approved there, about a 20% CR/CRI rate. And so, yes, we can use these agents in randomized trials. There's been a trend for improvement in survival, but I think we all agree, not a home run there. Recently, I think it was the MD Anderson group led a randomized phase 2 study of 5 versus 10 days of decitabine, showing no difference in the early analysis of relapse or relapse-free or overall survival. And we already talked about using azacitidine as a maintenance. So with that background of the deficiencies of our approaches for these patients who are some way unfit for chemotherapy, we do now have 2 new drug approvals, and we're going to discuss venetoclax, and we're going to discuss the hedgehog inhibitor, Glastigib. Let's start with venetoclax. Dan, you want to take us through that data and the FDA approvals?
Yeah, I mean, venetoclax has got to be one of the most exciting, therapies that we've been able to employ for our patient population. So just briefly, these are older patients that were deemed unfit for intensive chemotherapy by no real, prescribed method, but just a sort of gestalt about that. And there were a couple different ways that this was given. It was either given in combination with azacitidine or decitabine, and that was one of the clinical trials, or in a separate clinical trial was given with low-dose cytarabine. And there were some important differences between the 2 studies, but the upshot from the hypomethylator combined backbone therapies with venetoclax is, a response rate on the order of 70%, complete remissions, complete remissions with incomplete count recovery. And, really very promising duration of responses, going on a year for median, and survival that went well over a year in the median analysis. So, that prompted the FDA to grant approval for this regimen, and there is a phase 3 study that's currently pending that will compare azacitidine plus venetoclax versus azacitidine alone. When you look at the low-dose cytarabine data, similar in a lot of ways, lower response rate. It seems like perhaps a lot of that decreased response rate comes from the fact that this study permitted patients who had prior MDS and were exposed to a hypomethylator to go on and receive this therapy, whereas those patients were excluded from the azacitidine or decitabine backbone therapies. And when you account for the significantly lower response rate in those patients that had been exposed to a hypomethylator, then it seems like the overall response rate is probably more consistent between the low-dose cytarabine patients and the hypomethylator patients. So and that was also an FDA-approved therapy, and so there's a lot of permissiveness from practitioners in terms of what backbone therapy they like and prefer to use and are comfortable with using.
So now I'd like to get some very practical issues with this regimen, because it's clearly being used quite frequently at our own centers, but also by community physicians. And I think there are some real nuances that I'm becoming more and more familiar with, and I want to get your takes on them. I want to come to one point, though, about the transition to the phase 3. The sponsor had to pick a backbone, AZA or decitabine. They chose azacitidine. When I look at the toxicity tables from your phase 1b, it seems like maybe there was a little bit more myelosuppression and complications of infection on the decitabine arm than AZA. Is that why AZA was chosen, or it comes first in the alphabet? I'm not sure.
Yeah, that's interesting. I don't really know what went into the decision to choose azacitidine for the registration study. I personally don't have experience with the decitabine combination. Each institution basically chose or had to choose which backbone therapy to use. My take is that the side effect profile was pretty equivalent, but with smaller numbers, I think there's all kinds of different ways to interpret it. And I know that there are people out there who have pretty solid ideas about the toxicity profile of azacitidine versus decitabine as a single agent. So I think there's certainly the potential for a lot of variation there.